Happy Friday. Thank you all so much for being here. I imagine I've met most of you, but just as by way of introduction, my name is Leah Zickmund. I'm the executive director here at Hourglass. Thank you all for joining us for this very important and relevant session on healthcare in Lancaster County. Is anyone here at an Hourglass event for their first time? Welcome. I wanted to point out a couple of things. So at Hourglass, we focus on quality of life issues in the county, and we bring local experts to speak about those issues. I have a couple of resources on your way out if you didn't grab them on the way in. But one that I'm really excited about, it's an older document, but still exciting to me. We have our 25th anniversary booklet out there, which we did celebrate in 2022. But I was looking through it and realizing we have so many patterns of things that we've covered, so many important issues that we've done over the years. So if that's something of interest, just to take a look, please grab a couple on your way out and share with anyone that you think might be interested in our programming. I'm really proud and excited to introduce all of our speakers that we have today. And something that I've been noticing is there were a couple of similar events this week around the county. So I don't know if anyone was at the Lancaster Chamber had an event on healthcare this week. The United Way had an event on healthcare this week. And we're speaking about it as well. So it's a very relevant topic that we're, I think, all trying to understand who is solving these problems, who's working on them, and what can we learn from them? What can we learn from the changes that are happening right now? At Hourglass, we've written about and talked about this issue, and one of the statistics that I wanted to kind of repeat and share is that 1 in 5 people who enroll in state healthcare across Pennsylvania dropped their healthcare coverage this year. And so this is a concern, obviously, for who is speaking to and working for people who are uninsured and underinsured in the county and filling in those gaps. So I'm excited to announce or to introduce our speakers today in order of how they'll speak. First, we have Jimmy Reichenbach, the Chief Impact and External Affairs Officer at Union Community Care, who, if you all haven't noticed, just reopened a new facility on East Orange. It's beautiful, so hopefully he'll talk about that a little bit. Yep. We have Bianca Cruz, a street medicine nurse practitioner for Penn Medicine Lancaster General Health. And then finally, Tracey Lavallias, Executive Director of Behavioral Health Services at Penn Medicine Lancaster General Health. So we'll do our normal formatting. At the last 15 minutes, we'll do Q&A with our speakers. And before we get started, I want to thank our forum sponsors, Rogers & Associates, Shoemaker for our live streaming services, and the Ware Center for our beautiful space. So I will welcome Jimmy up here. Yes. You want to stay seated? Sure. That's okay. Well, actually, you know what? Standing up works.
At my advanced age, I should move around a little bit more, right? So thank you, everybody, for taking the time to come out today. Again, Jimmy Reichenbach from Union Community Care. I'm excited to be here. I know a lot of your faces here. It's good to see some of you again. Those who know me really well know I am very passionate about Union. I'm passionate about the work that I do, and I'm passionate about our organization. We are in some trying times in healthcare, but from our perspective at Union, we try to look at what we can do as opposed to constantly focusing on what we personally can't do, and we want to move forward. So there are some realities on the ground right now that are tough, and we're going to work through them because our community needs us. So collaboratively, we're going to make that happen, and one of the ways we do that is to talk about stuff openly and honestly. So that's part of what I'm going to be here for. So a couple things before we get into really what I want to talk to you about is just a little bit about Union, because if I didn't do this, my boss, if you knew her, would not let me back in the office. So we got to talk a little bit about our purpose and a little bit about why we're here. So really our goal here is at Union is to help you live your best life really from a whole health perspective. So Union has medical, dental, behavioral health, social services, in-house pharmacies, nutrition, and on and on and on. Probably something new got added since I've been here. We add a lot of stuff over time. But really that's our focus is whole healthcare. So what is the vision, right? So I won't read it to you word for word, but it really is about vibrant and healthy communities. Union Community Care's footprint is Lancaster County, Lebanon County, and Chester County. So we are a unique community health center in the sense that we have very urban areas. Many of you have seen them here in Lancaster City for a long time, over 50 years. We also have very rural areas. We have a location on Welsh Mountain in New Holland that's been there 50 years as well. We have locations in Denver, Pennsylvania, and all across the spectrum. Lebanon City as well, and also in Coatesville. So really the goal is vibrant and healthy communities, and how do we embrace each member of that community's culture and their specific needs. As you know, every community is different. So what are our guiding goals that we have, right? We really, at Union, we want to empower a culture that has a purpose. So almost anybody you meet that works at Union, they will talk about our purpose because we talk about it every day. So if you go to any of our locations, we have over 20 locations now. If you go to any of our locations, you will see these guiding goals laying everywhere. Our staff can't get away from them. Anywhere they can sit and congregate, they're there. They're on the walls. They're where our patients can see them because we try to live by those. Operational excellence is key. We'll talk about that in a minute. If you don't operate efficiently and effectively in a business mindset, you cannot survive the current conditions, right? So growing with purpose, innovate. We're really working a lot with AI technologies now to try to innovate and integrate that technology to where it can best be suited. So I won't read through these care values, but really they do focus in the highlighted area or the bold area of what it means for us to do the work we do. Try to find common ground for the greater good, these conversations. Part of my job is to go into communities and have very tough conversations. If we shy away from what's really happening on the ground, we're not talking about how we're going to move forward. So those conversations have to be tough at times. We advocate for change. I spent the first 3 days of this week in Harrisburg talking to our elected officials. Unfortunately, I missed you, Representative, but I'll get you next time, I promise. Yet you absolutely are there. She's always there for us, which is great. That was on me, not being able to connect with you. But rethinking health, what can health look like? Bringing health to people. We've invested in mobile units. We've invested in school-based healthcare. So in the school district of Lancaster, we have 4 healthcare locations in the schools. It's great for parents. They love it. They don't have to send their kiddo home. We see the parents as well, and then we also see the community at large. So it's great, right? And then being a good neighbor. We just moved in, as we mentioned, to a new location less than a block from here at the former Groff Event Center building. Some would call it a funeral home. I don't call it that anymore. Not a former funeral home. It was an event center, and now it's an amazing location. But being part of that planning was to connect with the Landis Homes community right behind it and make sure that we were going to be a good neighbor. We can't just come in like a bull in a china shop and set up things. So we made great relationships there, and it's worked out well so far. All right, so let's talk about what really we're here for. From our perspective, the biggest issue in healthcare right now is the insurance crisis. We've been talking about insurance coverage for a decade, probably more, and we've talked about, man, in a few years, things are really gonna be bad. Man, in a couple years, things are gonna get crazy. It's now. It's not years from now anymore. We're talking about months now. We're not talking about years. The impact is massive, and it's hitting us all at the same time. So what's happening? Rising cost and affordability. I don't have to tell anybody about that. ACA premiums spiking up, people dropping off, as you mentioned. It's awful out there. The costs are high. Coverage instability. Employers, understandably, can't afford to get insurance for their employees because of the skyrocketing cost. They drop coverage. Employees are without health care. Medicaid redetermination challenges. I won't go into too much detail with this because I'll get too passionate about it, but the reality is there are so many challenges now for people to even enroll in Medicaid that oftentimes through bookkeeping errors, people don't get insurance. And then by the time we figure it out, they drop off and they disappear. And then the strain on the safety net providers, LG, Behavioral Health Hospital, ourselves, everywhere the strain is high. So what are the drivers? Where's this coming from? Obviously, healthcare costs are going up everywhere. Everything costs more. Everything costs more, not just in healthcare, but included in healthcare. Medicaid unwinding, again, I could spend hours talking about that. I won't bore you with that. Unfortunately, it's not a boring topic. It's a really frustrating topic. But the reality is having people have to drop off coverage and re-enroll leads to errors and challenges and people not being back on the books. And that is happening all over the place right now. Employer insurance challenges, again, I already mentioned that. And then the simple fragmentation of the market. I don't think 50 years ago when we were thinking about employer health care, a little more than that we thought this is how it was going to end up. It was a pretty good idea at the time. This is not what we thought was going to happen. It is brutal. It is fragmented. It is hard to understand. And it's filled with middle managers the whole way down the line that make it almost impossible to tell you about the true cost of your health care. So it's hard for people to wrap their mind around the challenges that we're going through right now. So I'm going through this a little quickly, but I want to make sure I don't take up too much time, and then we'll definitely go, with the Q&A going forward. Where are we seeing the direct impact right now? And this is really where the rubber meets the road, right? Increased patient complexity. What we're seeing for these people that are dropping off insurance is they're not going for care and paying out of pocket. They're just passing on care. So what happens if you decide to not treat your pre-diabetes or your diabetic condition or your other issues that you've been dealing with that are chronic? They don't go away. We know that. Everybody in this room deals with something, or their family member does. So what ends up happening? They go to the ER, right, which are already overburdened and overtaxed, or they come to Union a year or 2 years after, uninsured. We are absolutely going to see them, no questions asked, whether they can pay or not, but they're already so far down the road. So what does that mean for the system? More insurance, or more cost out of pocket. It means more medication they're going to have to get at the pharmacy, and on it goes, right? So it's not a good situation. Financial and operational strain. How many people in here are business owners or used to be business owners? Okay. So what if I told you that year over year, from this year right now to next year, over 10% of your current customers would no longer pay for your services come next year, but they're still going to get your services. You're going to give them the service that you currently provide your customer, but 1 out of every 10 people that walk through will no longer pay for that service. That is the reality that's happening on the ground right now. When we say it like that to business people, it resonates. It's like, well, who could sustain that? Nobody. But that's where we are right now. Now, as a community health center, doesn't matter. We're not going to turn anybody away. But the reality is there's not an unlimited bucket of money sitting somewhere for everybody. So how do you deal with that? You start to cut services. Maybe you don't offer dental. Maybe you don't offer urgent care. Maybe you cut hours. Maybe you cut days. So those things are coming in the future, not necessarily here at Union. Thankfully, we're in a relatively strong position. But our rural partners out in the community, think about places like New Providence, Quarryville, Peach Bottom. People that have to go 30 minutes to get to a health center, and now you're going to start to close more rural locations. It's a challenge that we don't want to see. And patient trust and engagement, ask anybody or anybody in this room who tries to navigate healthcare right now, you can't. You don't even know how to do it. It's tough. So I want to stop right there and just kind of summarize, and again, happy to take questions going forward. I think the messaging, I spent a couple weeks a year in DC as well. We're blessed to have very good relationships with our federal and state elected officials because we work hard at it. And there is understanding. Healthcare is still one of those issues that's relatively bipartisan. You can have conversations about healthcare with people. The challenge is I don't think there's a real understanding at the federal level of the economic impact of what is already here. We are too late to fix what's coming right now. All the people that are off insurance, that's a done deal. The Medicaid unwinding, done deal. AKA subsidies, done. The one big beautiful bill has happened. So we can talk about whether or not all that was the right thing, the wrong thing, but the reality is the outcomes of that are now. So the challenge is, as a community, how do we support our community through what is? So it's no longer, again, years down the road. And I certainly don't want to come off as pessimistic, but we want to talk about the realities of how we have to support our community. And it's going to take everybody to be able to do this. So I just want to kind of leave with that, is we are in a tough spot. I can't pretend that we're not. But we do have state elected officials that really do understand and are trying their best to help. And we do have federal elected officials that I think understand, but I'm not sure if anybody's turned on the TV in the last, 10 years. But it's very, very difficult to get anybody to move forward legislation that increases even $1 worth of money into whatever system you're looking to do. So that is the challenge of our time. But again, Union is here to do the best we can to work through that. So can't wait to take questions. Happy to talk to anybody afterwards. This would be a 3-hour presentation that I'd be hammering the thing on, but because I can only talk 15 minutes, that's all I get to give you. So appreciate you. Thank you.
Hello. Right. Yeah, can you guys hear me? Thank you. I'm very short. My name is Bianca Cruz. I'm a nurse practitioner for the street medicine program that's currently run through Penn Medicine, Lancaster General Health. So street medicine, the philosophy of street medicine has arisen both nationally and locally in an attempt to mitigate poor outcomes for people experiencing homelessness, to reduce the suffering associated with homelessness. This means an entirely different approach. An entirely different approach. It is the direct delivery of care to people experiencing homelessness, meeting people where they are, in streets and encampments and other non-traditional settings, while trying to address the immediate medical needs and the broader impact of the social determinants of health. So this is the philosophy of street medicine. I just said that, but sorry. The main tenet of the Street Medicine Institute, which is a formal international organization for street medicine, is go to the people. That means literally go to the people. We try to engage in a flexible, reality-based approach on what is possible for our patients on the day we meet them at that time, maybe even for that hour. We provide non-judgmental care that values personal autonomy. We try to be as authentic as we can with people. We work as a multidisciplinary team, which includes people, social workers, mental health providers, and we also work with lots of partner agencies providing different care or services that we don't necessarily provide. And we show solidarity both with our patients and with each other as a multidisciplinary team. So street medicine team, we are a core team of myself and a family physician along with a RN care manager. We do a collaborative approach alongside multiple community agencies. We do shelter and street-based rounds every week in Lancaster City, and we have a consistent presence at several homelessness services providers county-wide. So the three of us cover the entire county of Lancaster. We try as best we can. We have rotating visits to Columbia, Elizabethtown, Ephrata, Lincoln Highway Corridor, and other sites as we're called or we're made aware of things that are happening. And we have targeted outreach to hospitalized patients at LGH and Behavioral Health Hospital. You will find us in shelters and day centers around Lancaster City. We visit with partner agencies and try to optimize care and follow-up. So if we're looking for answers, we got to ask the questions of why are people experiencing homelessness? Some of these are individual vulnerabilities, some of these are structural vulnerabilities, some of these are controllable, some of these are not controlled, but there's lots of reasons why people find themselves without a home, without a support system. Anecdotally, a lot of our people experiencing homelessness often tell us they feel like they're on the outside looking in. The suffering they experience is one, of course, of material deprivation and the perception or reality of poor health. But in many ways, the core of the suffering that they have is of a spiritual sort that kind of arises from the experience of constant exclusion and seclusion away from society. Any solution for the people experiencing homelessness has to address the health concerns and the material needs, but also the deeper, broader concerns, their soul. So you have to treat the person and not the disease, and that's what we're trying to do. Ooh, rising house costs, low supply of affordable housing. So I just got the new numbers yesterday, so I apologize, this is not the most updated numbers. So people experiencing homelessness in Lancaster County are counted on a yearly basis in January, called the point-in-time count or the PIT count. So last year, it was 546. The numbers that were just released yesterday by the Homeless Coalition, we're at 665 people experiencing homelessness in Lancaster County that were counted in January. And so that is an increase from the last couple years, and it's actually the second highest number since 2009. So we had a 9% decrease in 2024, though the unsheltered count remains historically high. And extreme cold weather, it was the coldest day of the year, I'm pretty sure, had an effect on the 2025 numbers that we have. So healthcare utilization trends, these are two different studies, one in Boston and one in Toronto. Boston, the patient's average, this is age and sex matched to UMass health population. Compared to one ambulatory visit, people experiencing homelessness had 10 ambulatory visits, 4 ED visits, and 1 hospital stay per year. Mass Health, which is their Medicaid product, also reported spending $2,036 per member per month versus $500 amongst the general population. These numbers are a little bit old, so I bet that these numbers have increased since then. And almost half of the total annual expenditures by Mass Health program were incurred by 10% of the population. So there are some people that are not having their needs met, and that shows in increased healthcare costs. In Toronto, the rates for homeless participants compared with their controls were 1.76 to 1 for ambulatory care encounters, and ED visits, the average person had 1 ED encounter. A person experiencing homelessness had 8.48 ED encounters and 4.22 to 1 for med-surg hospitalizations. Another number that's included that I did not put in this slide is that people experiencing homelessness had 9 mental health visits compared to 1 visit for the typical population. So street medicine statistics. In 2024, this is our program-specific numbers. That was the first year we were really starting, because we started in the fall of 2023. We had 466 distinct patients with 1,196 encounters, with hundreds more formal encounters. So some people who are not really having a medical visit but wanting to talk to the nurse care manager, or wanting to just have a blood pressure checked but not really do anything about it. We have tons more interactions face-to-face with patients than we're able to quantify. 2025, our patient number went down, but our visit number went up, so showing that people are trusting us maybe a little bit more, coming to us with their chronic care needs. Out of 2,500 ED and hospital encounters at LGH in 2025, of people experiencing homelessness, nearly 400 of them were able to follow up with us in 30 days, which is great. So how are we doing this? We are doing the best we can to kind of build trust and engage in trauma-informed care through consistency and presence, which is not atypical for a healthcare organization. But many individuals have the feeling of being stigmatized or discriminated against in clinical settings, feeling rushed, dismissed, judged, or very frequently have instances of prior trauma, including institutional trauma. This leads to delayed care seeking, a preference for the ED because it feels more accessible, and the reluctance to engage in long-term care. So we're doing our best to build trust through a consistent, respectful presence. The healthcare environment itself can sometimes undermine treatment plans. So even the best clinical plan can fail in the wrong environment. Something like wound care, something as simple as wound care should be, can fail when patients have to walk miles daily to access meals, to take their belongings to their storage unit, when they lack regular hygiene access. Diet recommendations for heart failure: have a low-salt diet. That's difficult to control when you're relying on community meals that are providing the meals for you. And if they don't have food access or control, they have to, they kind of deal with what they have. Medication adherence is compromised by theft, cognitive impairment, and competing priorities. A word I made up today is unsilo. So I'm trying to unsilo the care. Traditional medical practices will often say, well, you go to this building for one thing, you go to this building for the other thing, and oftentimes there's a wait for providers or appointments, and it's very difficult to wait for that when your daily subsistence needs are not being met. So we do our best to bring as much care as we can to the people experiencing homelessness in a place where they're comfortable. Yeah. So the reality is that these conditions of substance use, behavioral health, homelessness, blood pressure control, diabetes, they're deeply intertwined, and the access points can feel fragmented, and requirements can be hard to navigate, overcome the barriers they experience every day. So it's really difficult to expect patients to navigate a complex system when they are also in crisis. And so the other thing we try to do with street medicine is measure differently. Healthcare providers typically measure visit numbers, billing, throughput, which does work. We measure those too. For our population, however, success might look like agreeing to a follow-up, something as simple as, yeah, I'll come look for you next week when I'm in the city. Trusting us enough to disclose symptoms that they haven't told anybody for a while, or even just to tell us where they've been sleeping, because sometimes that's a secret that they don't like to share. It can be something simple like accepting a blood pressure check after months of refusal. It's difficult to measure relationship-based care with traditional metrics, but we do our best to try to keep ourselves motivated and remember our individual patient success stories. So street medicine statistics, why are you do that? Oh, I went backwards. I'm sorry. So without stable housing, chronic disease management is much more difficult. Recovery is very fragile, and hospital discharges and recovery plans can fail. We are asking people to succeed in a healthcare system that requires stability while they themselves are frequently unstable, and so that's really difficult. You can treat infection, stabilize conditions, but discharging someone back to the street can undo the care that was just provided. And so I just wanted to give a shout out to our partner organizations. Union Community Care is there. We have Penn State Health there, Echoes, Water Street Rescue Mission. So we are working with everyone we can, tons of outreach teams, other medical providers, anyone we can to get the care, the supplies that we need to just get people places where they can be safe, where they can be comfortable to disclose to us their health, their health needs and some of the struggles they've had. And that is it. Thank you.
Thank you. Thank you so much. First of all, thank you for having me here. Give you an opportunity to kind of talk a little bit about Penn Medicine. We talked a little bit earlier, you heard a lot about the ED. Just to give you a little bit of perspective, I'm in charge of the behavioral health service line, which is from the emergency department to Lancaster Behavioral Health Hospital to our ambulatory sites, our primary care sites, our crisis walk-in center. So about 35,000 adults we see a year, about 9,000 of those are kids. About 5,700 of those come into our emergency department to receive care. And we just started our crisis walk-in center. We've been open for about a year. We see about 190 or so, 150 some months of the individuals that walk in. So I'll give you a little bit of an idea of sort of what we're seeing on the ground, what our response is to try to deal with this issue from an insurance perspective, and what we think some of the long-term impacts will be. So I'll get a couple slides here, and I'll kind of go through them. So what we see a lot is patients that are moving just in and out of insurance coverage. And so, we talked a little bit about it earlier, is they start out with coverage lapse. We are in a carve-out state here in Pennsylvania. Unlike some of my colleagues, I'm on the American Hospital Association. I kind of talk a little bit about some of those individuals that are on the West Coast where they have a carve-in. So we have a carve-out state here, so you have behavioral health insurance that's separate from your physical health insurance. So it just makes it very, very difficult to navigate. Now, on top of that, you have these complexities related to Medicaid and the enrollment process. So it just gets very, very complicated. I'll talk to you a little bit about what we're doing related to that. But the impact of that is it's delays in care. So sometimes you come to an outpatient site and you think you have insurance, you look it up, you go to run it, and you don't have the care. So what that means is we can't treat you because we don't in our ambulatory sites, we don't accept individuals that don't have insurance. And so you go back and you try to re-enroll, so that delays the care, especially when you're in immediate need. We talk about where they usually end up, and that's the emergency department, but I'll talk a little bit about that in a second. And then you just have some of those individuals that are underinsured, don't necessarily have the amount of coverage to be able to cover the care and treatment and to be able to impact the services that we currently provide. So just give you a little bit of information on that. So the increased pressure on the emergency departments is very real. One of the reasons why we opened up the crisis walk-in center, the crisis walk-in center does take individuals that are uninsured. I talked about that 5,700 individuals that come into our emergency department. We're seeing an increase in kids that are coming in. Lancaster Behavioral Health Hospital is seeing an increase in kids, and many of those are uninsured. So from an emergency department, that's not where we want our patients to be. It's a boarding process for many of them. We're pretty quick in our emergency department. Nationally, when I have conversations with individuals, they say 14 hours, some 24-hour, 48-hour stays. We do about 7 hours. Even in the best case scenario, you're coming in, you're seeing an emergency department doc, and you're getting discharged, or you're going to someplace like Lancaster Behavioral Health Hospital in about 7 hours or so. So it's increased pressure, and it's boarding component. So there's growth in our crisis presentation. So the largest growth that we've seen in our crisis walk-in center has been those individuals that are uninsured. We expected that. We have a grant for it. We also have some philanthropy dollars, so we're very lucky from that perspective. We have some various generous donors in this community, so they're helping us cover those costs associated with those individuals uninsured. And the community has been very grateful for that. We get a lot of positive responses, obviously, for being able to cover those costs, but that's not the reality for the Commonwealth. Longer wait times, I've talked about that just a second, and I talked about that earlier, rather, and that's just based upon the fact they don't have insurance. They don't know they don't have insurance. And then there's just the navigation challenges that I talked a bit about before, the fact that there's a carve-out component. So we've seen that increase that has been happening. And it was mentioned earlier that the complexity of individuals with behavioral health has increased in Lancaster County. So not only has the increase in just general patients with behavioral health, the complexities of the conditions that they're experiencing has been increasing, meaning that we see a larger amount of higher risk patients that come into our services. The Crisis Walk-In Center is meant for low-risk patients. That means individuals that come in and score a 4 or less on the Columbia Suicide Screen. That's just a screening tool that is used throughout our system in most hospitals, and that just differentiates the difference between low risk and high risk. We've seen a number of individuals utilizing that. Many eligible for Medicaid, but they lack the resources and wherewithal how to navigate that. We have resource counselors within our Crisis Walk-In Center. They are sitting those individuals down, helping them walk through. We have the impending impact of what that will look like in the future with this mandate for to work, and also the complexities of enrolling. So that was touched on really well there. There's many complications in just how to navigate the system, what website to go to, insurance verification components, Social Security, the technicalities of staying enrolled is just very complex. And so compounding that, if you have a mental health challenge and you're coming in and you know, trying to navigate the system, it just makes it very difficult. Some individuals throw their hands up and it's a circle of motion. They go to the emergency department because that's the default for individuals that don't have insurance. And I just told you we have a very generous community. They have been helping us with this uninsured population. Crisis Walk-In Center is coming increasingly an alternative. Individuals can come into our Crisis Walk-In Center. We have peer support specialists. We have access to psychiatrists. We have access to addictions medicine specialists. We have access to nurses. A significant amount of individuals that come into our Crisis Walk-In Center not only have conditions that mask itself as behavioral health issues like anxiety, those are sometimes physical health issues, and we have the ability to sort of move those individuals to the ED if they have any medical challenges. We also have integrated behavioral health in all of our primary care practices, and we've found an increasing amount of individuals that are uninsured in our integrated practice, meaning that integrated practices are in all of our primary care practices and some of our specialty care practices, we have behavioral health counselors. So we make it seamless for you to go to your doctor from a primary care perspective, and if there are some challenges from a behavioral health perspective, you can walk right down the hall and talk to a behavioral health counselor. In some cases, there may be physical health insurance because the individual come in, but you walk down the hallway and then we find out that you have a behavioral health challenge and there's just a lack of behavioral health insurance or no behavioral health insurance, so that just becomes an issue for us. So we try to have some active support in our integrated counselors to be able to help those individuals become eligible for Medicaid. So a significant unfunded component of our time is helping individuals navigate the system, enrolling them, and as opposed to providing therapy. So in many cases, you have a lot of our therapists, a lot of our counselors involved in some of the enrollment components of their care because they want to care for their patients, but at the same time, they want to deliver therapy, and so it takes away from that, and it's unfunded. So we just need a better community-based partnership related to that, upstream and downstream, meaning that higher level care and lower level cares, and we're trying to work to make sure that those partnerships exist, not only within the clinical healthcare continuum, but also from the philanthropy perspective. So where do we go from here? Individuals need to have access is the way we see the services. We know that our suicide rates, you've seen in the community that there was a recent article about the suicide rates that went up, and I was interviewed for that. And one thing that didn't make it to the paper was I stated that we don't see that level of increase in suicide from individuals that come into behavioral health services, meaning that if you are assessed for services and you receive care, that suicide rate goes down. It's individuals, over 50% of the individuals that commit suicide have not even entered the system. So they don't have a mental health diagnosis. So there's a misnomer that individuals that commit suicide have behavioral health conditions. Well, we know that 53% of them don't. There's life conditions, stressors, and those types of things. We know that if you receive services and get connected to some type of behavioral health support, that that rate goes significantly down. We knock on wood, we have about a 1% suicide rate from those individuals. We quit tracking the metric because we did well, meaning the individuals that come in, you get screened, you get assessed, you get treatment at 1%. So we know that components of care works. So early access is definitely something we want to do. We need to have community and health system alignment. So this is a partnership. I always say, you know, I have I'm the only behavioral colleague in the system, in the Lancaster system, and I deal with individuals with cancer and neuro and all different parts of our service. They can get their jobs done internally. A percentage of my job can be done internally, but most of it is community-based, dealing with individuals like yourself, other health systems, Union Community Care, and other individuals. It's just a system that we need to have, and it's beyond the walls of the hospital. So, sustainable funding, we certainly need that. We have some challenges with, I don't know how many people know what Institute of Mental Disease is, but that's being challenged at the federal level, and what that is it restricts certain reimbursement costs for individuals that need inpatient care. So there's another challenge just from a sustainable funding perspective. And then, you know, focus on access, not just capacity. And we talked about that, being able to build a continuum. I try to look at it as individuals that need behavioral health care, they're not a monolith. Some need, you know, more high risk level care, and some need low risk, and then all the things that are in between. And so we need to be able to meet those individuals where there's access in all those doors. So, you know, the whole saying is no wrong door. That certainly is the case. Individuals need a continuum of care. And so we've been trying to work with internally as well as externally to try to build that continuum of care. I'm fairly passionate about this topic. I live it every day, and I often get an opportunity to sort of go around and talk to individuals on a national level. And when I go in some of those rooms, one of the things that sort of heartens me is, you know, you're talking, you've got individuals from Texas, Ohio, and we start having conversations, and we're all experiencing the same thing nationally. So it's not just a Lancaster issue, it's not just a Pennsylvania issue, it's a national issue. And so hopefully with individuals like yourself, we can sort of turn the tide. Thank you for your time.
We don't always have time for this, but I'm going to do this today and send the microphone around. If you would, even if you don't plan on asking a question today, just so our speakers know who you are. So if you would share your name and who you're here with, if applicable, and just pass the mic along, and then we'll do questions.
I'm Chris Weicker. I am here representing Quest for Learning, a program for lifelong learning for people of retirement age. And actually, we just want to...
Just intros for now.
Just intros, sorry.
Okay, thank you.
I'm Coco Fulton. I'm here representing Fulton Private Bank and Fulton Financial Advisors. I'm a private banker and newly appointed to the Hourglass board.
Tim Stuhldreher, Strong Towns Lancaster, and Power Interfaith Housing Work Group.
I'm Adam Heaps. I'm the executive director at the Clinic for Special Children.
Hi. Aaron Sherman, president of Odyssey Group Wealth Advisors.
Susan Eckert. I'm on the Hourglass board.
Joshua Druce, Janus Capital.
I'm Dr. Nancy Mannion, registered nurse and candidate for U.S. Congress.
Michelle Salinas with Your Language Connection. We provide language services.
Lori Johnson with a candy factory, and I've been in this system for quite a few years, so I'm really interested in what we're doing going forward.
I'm Jason Mundock with the Candy Factory co-working space and So Good Media.
Rich Nazaro, just a citizen, and I volunteer with Lancaster Stands Up.
Andy Polyak-Shank, I'm a consultant working with nonprofits.
Brian Davison, president of Davison Associates, we're a commercial real estate brokerage, and Hourglass board member.
Kate Lowry with Higher Information Group. This is my first time here as Doug's guest.
Hi, Doug Groff with Scenic Ridge Construction.
I am Ryan Shank, Executive Director of the Red Rose Film Festival, and just happy to be part of the conversation.
My name's Doug Harris. I'm relatively recent
recently moved to Lancaster and a volunteer at Food Hub and just interested in trying to learn what's going on.
I'm Clark McSparron, a pediatrician. I was 18 years a school doctored volunteer at Carter and McRae.
I'm Jose Garcia. I'm a marketing manager at Assets Lancaster.
I'm Angie Schumann, Penn State health nurse, community health nurse.
Nikki Rivera, state representative here in Lancaster, House District 96.
I'm Jake Gandy, insurance advisor with Enders Insurance.
Sam Bresci with Lancaster County Community Foundation.
Art Man, Hourglass, but also in our companies we have about 1,000 people, and we have our own private insurance, medical. So we have have experience in this field. Trust me.
I can start with you, Chris. I know you had a question. If you want.
I was at a presentation yesterday on mortality in the U.S. versus mortality rates, life expectancy really more in versus other developed Western countries. And we spend sort of double what most of the Western European countries spend per person, and yet we have lower life expectancy. And it went through all of the causes. And the one thing, I mean, we know a lot of it has to do with the issues that our panelists have spoken about. But the one thing that really hit me was not getting the health care early, not getting preventive health care, and particularly for children. So I wanted to ask, when you're doing these outreach programs to people on the street, some of the homeless people have children with them, and certainly people that are in Water Street and some of the rescue places have children. Are you able to get to the children to get them the basic health care and immunizations that they need to start them out on a good path of life?
I will say that in the last 2.5 years that I've been doing this, I've had 2 or 3 children as patients. Most of them are connected with primary care providers. A lot of them here in Lancaster City see Union Community Care. They have a very robust vaccination program, so we're very glad to kind of refer people back into the system as we can get them connected. But yeah, I've thankfully not seen very many.
Hey, Joshua Druce, and thank you all for the presentation. Jimmy, I had a friend of mine about a week ago that was a patient of Union Community Care, and he was talking about just how great of a job they did and how grateful he was. He started out as a dental client because he couldn't afford basically anywhere else, and his entire family's now been there for a few years. So I have a question for the whole panel, primarily Bianca. With the entire change in landscape in the spectrum of substance use treatment, Ray's Project is closed, White Deer Run is closed, Retreat has closed, and maybe reopening under a different owner. And then just the cuts to Medicare, the treatment spectrum has changed dramatically. So I imagine that shows up very prominently in the work you do. Just curious how big of an impact that has been, and I guess what impacts you guys are seeing.
We certainly do see it. I will say we have a good, it's called a post-overdose recovery team through our community health department at Penn Medicine. They keep track of a lot of the statistics. They do a lot of community training for overdose prevention and Narcan use. We also do several times a month round with blueprints for recovery. So we go out with their workers, they come out with us, and we all just kind of move forward, seeing patients and kind of referring patients back and forth as needed. A lot of folks will come out to, if they see you together, you're all together. So they will approach an outreach worker who has nothing to do with substance use and say, I think I'm ready today. And so that outreach worker reaches out to anyone they can find, whether that's us, medical team, so that we can reach out to blueprints or whatever, substance use, recovery places are available, but we all kind of work together. We receive, supplies through the state. We were receiving supplies through RACE, which is now closed. And it is certainly a challenge to kind of refer people out to recovery and rehab centers with them closing, but we do the best we can to keep everyone as connected, when they're ready for it.
only thing I would add is that I guess there's some good and some bad news to it. I think the good news is before COVID, our opioid deaths had increased. I think recently we're part of Joining Forces, which is a community-wide initiative, and that component has come down. So we have seen some of those opioid deaths decrease in our county. The other component is that there has been an increase in those individuals that we're seeing in our emergency department, also our crisis walk-in center. Of that 5,700 patients that I talked about that have a behavioral health complaint that come into our emergency department, on a yearly basis, about half of those are individuals that have substance use disorder. And one of the things that's different than other states, you can commit an individual that has a mental health issue. Individuals that have substance use, you need to work with them to determine their readiness, and we have individuals to do that, but sometimes it makes it a little bit more challenging.
Good. Okay. Curiosity. A lot of this seems like the consequence of choices that were made by the end user of your services. What is being done, or what programs from an outreach perspective are available to people who don't know that they need your service yet? And by that I mean those who don't know they need help from a marketing or from an outreach perspective. How do you reach those people?
Sure, it's a great question, and there's no one single way. Particularly when you cross such large footprint. LG, our friends at LG and Penn State Health and Wellspan UPMC, so large footprint organizations, union as well. So it's different for each community. We have a robust mobile health team. So we have a mobile medical unit and a mobile dental unit that gets out into the community and works with partners in the community, not necessarily medical aligned. Partners in the community just kind of set up shop in a parking lot. Hey, we're here, what do you need? Vaccinations, well child checks, things like that, dental screenings, things like that. There's some traditional marketing that goes into it, but it really is about immersing yourself in the communities and getting on the ground, particularly from a community healthcare perspective. If we're not on the ground, people aren't going to know about it. We are blessed, but we also see the ramifications of the challenges that we have, that many more people are finding us now than ever before. And I think what is really surprising, I think it's surprising people in the community, not necessarily us, but it is surprising people in the community, is that there are people that are now seeking out our services that I think in their mind never thought they'd need us. That's a completely different scenario than where I think we may have been 10, 15, 20 years ago. We all need help from time to time. We all know that. But I think there is a population now that is intentionally seeking out our services, and they almost come embarrassed, which they shouldn't be. Nobody should be embarrassed to take care of themselves. We're all on this crazy life trip together, but are like, please, I need this help. I never thought I'd be here. So I think it's a combination of things, not one size fits all for any given community. Rural health, obviously, we're not going door to door in our rural health, but one real brief example is we have a Plain Healthy program in eastern Lancaster County that every week we do a loop in our Plain community and stop at different homes and different community hubs. And we do vaccinations, whatever they choose. There's no prescription. If there's certain things they want, we do well child checks and things like that. So in that community, we realize if I put something down on social media, they're probably not going to see it. So how are we going to get to them? We're going to drive right out into their community and do it.
If I could just add on to what you said, I think you did a really nice job of sort of rounding it out. I think, some of the things that you're talking about is the stigma associated, particularly from a behavioral health perspective. I've been doing this for about 2 decades now, and I think we've come a long, long way. There's been some campaigns that we've launched, the 5 signs, that happens with a layperson being able to identify individuals that may be going through depression or suicide. There is mental health first aid in the same way we deliver first aid as a life-saving measure for individuals that have a physical issue. There's the same thing so I think those types of things go a long way. We're still not at the place, and I think this forum here is really great at a place to where we can talk about mental health in the same way we talk about, cancer or or any type of other detrimental, that we still haven't gotten that yet, and that's one of the things that before I retire, I hope we'll get to be able to talk to that, because I think being able to talk to it as openly as we are now will sort of reduce the stigma and allow people to get the treatment and services that they need.
And to piggyback on that, visibility is absolutely the number one way that people, are aware of what's going on in the community. And I think it's also the community's awareness of what they offer and kind of seeing where those gaps are. Permanent supportive housing, housing vouchers, things that would allow people to get into housing. If there's anything about research about homelessness out there, everything shows that housing someone first and then working on their problems from there works. So we're at a deficit of affordable housing, of units that are available to the general public, and it's really difficult to access. So being visible and awareness, like forums like this, of making people aware of what we're offering and maybe where we'd like to go so that everyone knows where to refer your neighbors.
Thank you for the the information today. Every time I come to these First Fridays, I learn a lot of new things, especially when Jimmy talks really, really, really fast with a lot of words, and I get a whole lot of new information. I love it. I went to an event yesterday and got a legislative update from one of your hospital counterparts, and I just wanted to give you a shout out because Penn Medicine was named and got a shout out from a counterpart hospital that you do value-based care rather than fee-for-service. And so what that means, and when I looked into it more, what that means is that you're rewarded at the hospital for outcomes, not volume. And you are rewarded for you're paid based on the quality and total costs of care, not on each individual test that you order and rack up money for. So just the fact that we have Lancaster General here in our city doing what other people are deeming a really great model for serving our community. I'm really excited to hear about that. What I wanted to mention, though, is that I at the State House, we talk a lot about AI and how to put guide rails on it and how not to let it be a runaway train with a lot of issues, but also how to keep the human at the center of decision-making and at the center of a person's actual care. With AI as a tool. Are you finding in what you do in street work and in the school setting of healthcare and in behavioral health that you are able to implement AI? Are there barriers? Are there things that I as a representative should know that would make life easier for you to get to more people?
I'm sorry.
I will say in the current street outreach work I do, AI is a little bit difficult to implement. Sometimes the only technology we have is our cell phone, and it doesn't always connect. So I do office-based patients as well, non-street medicine patients that I am able to use AI for, but it's difficult in the outdoor setting. I think it's certainly useful for afterwards, for charting afterwards or trying to collate information that would be helpful, but we don't currently use it with our outreach efforts.
Thank you for the question. It's a very good one. We've been talking a lot about that, so it's very timely. We are transitioning to a new payer for my ambulatory sites, and one of the questions that our provider community brought up was the institution of AI. We've obviously made some commitments internally that it would not go into the therapy component. I think that's a component that many individual therapists are concerned about, and we think there's a value to the human connection. We do think there's a role for AI as it relates to matching patients. I think there could be a role in AI as it relates to dealing with some of these Medicaid issues, as it relates to some of these just enrollment types of things. So we're looking to make sure it's a part of the component of care, but not the actual delivery of care, if that makes sense.
And I agree completely, co-sign that. I think where we're able to leverage it so far has been appointment scheduling, reaching out to thousands and tens of thousands of patients where an individual would take hours or maybe days to be able to do that. Provider matching, also helpful. And again, love the comment about enrollment. The ability to utilize AI to navigate some of these challenging things that could maybe cut it down, to the 10th of the amount of time or the 100th of the amount of time, allows more people to get enrolled, and it just is great. And also, we have providers who do not love the idea of AI as being a tool in the therapeutic process. So I would say, if anything else, as you're looking to do the legislative work in your role, I just would strongly encourage you to listen to the providers, hear them. There's a lot of other people with a lot of other opinions, but the people that are dealing directly with humans, that's probably who you want to be listening to.
So I'm curious, I've kind of a two-part question. First of all, I know, I'm just curious about we have a big diverse population here in Lancaster County. So I know medical facilities do use interpreting and translation consistently. How do you tackle the cultural boundaries? Because you go into the plain community because their culture is different. And Spanish population has been here a long time now that a lot has changed in the localization of translations and bringing interpreters in and knowing what's going to cause their high blood pressure as opposed to the Anglo. But I'm just wondering about all the other communities like Nepali and Afghani and those communities that, they've grown up on refugee camps. They come with trauma. They come with the shame of mental illness or the shame of asking for help. I'm just wondering what you see when you go to the homeless population in diversity or when you're tackling the mental health care and the other things. How are these populations showing up and how are you handling those cultural barriers?
I'll talk a little bit about from LG's perspective. We see a lot of those individuals in our emergency department. We don't see them, and it's just not just Lancaster General. We did a presentation nationally, and it happens nationally, where they're not doing the preventative medicine. They're not going into the primary care. There's a lot of shame and guilt. There's a lot of masking that occurs. And so what happens is that they end up waiting until the incident that they're dealing with gets so unbearable that they're either involved with police or someone takes them to the emergency department, and then that's where the break happens and we have to work. We're trying to work to get upstream on that, to do non-traditional, the barbershops, the mosques, the churches, synagogues, in order to be able to meet them where they are, because they're not engaging us in traditional forms where we might meet the majority of our potential patients in our primary care offices because they go on a yearly basis to get their yearly physical. These individuals aren't. So we have to be more non-traditional until we have some outreach efforts that we're putting in place to do that on our community health side of our organization.
I will say that it's not typical to be sitting in a park and look up and you see a doctor willing to take your blood pressure. So I think starting by being non-traditional is helpful for our patients because they realize that they don't have to present in a way that they might feel like they would have to present in an office. So that is helpful, just kind of being outside of the normal, being out there with them, making sure we can communicate. So we do have a translator line that we can call to talk to them. And really it's about spending time and getting to know them, not just culturally, but personally. Like what do they do? Where do they eat? Where do they sleep? And anything that they would be willing to share that would allow us to understand more about them as an individual. As we encounter more people of the same culture, like our Nepali population, it's helped us to kind of understand a little bit more about what their needs may be. But it's all about, talking to them and allowing them to tell us and kind of dictate their care, what they're willing to do, what their understanding is it, what our understanding of it is, and just kind of making a plan of care that we're all in agreement with.
And I know we're short on time, so really quick, one of the things we're doing is our translation services, but also our documents. So for generations, everything's been in English and Spanish, to connect with those communities and make sure that they feel valued as well and seen. We do a tremendous amount of paper translation and flyer translation and online into numerous languages at this point. So it's not just English and Spanish and then maybe using a translation service. There's actual physical documents that we're able to share back and forth to be able to connect.
Thank you. Great. I did want to honor that we did have a question online. It's for you, Jimmy, and it's a yes or no. And if it's more than a yes or no, maybe we can. Someone did say, "Wonderful panel, thank you." So thank you. Does Union Health now see their organization as the provider of last resort for Lancaster City and County residents? And if it's a no, maybe a more complicated answer.
It's a more complicated answer. Sorry. I'd say no, just because of the way the question is worded. But yes, we're here for everybody.
Okay. Well, I want to say thank you to our panelists. When I was walking in, I bumped into someone who was saying like, "Oh, we just made it through our busy season and I can rest now." And from hearing from all three of you, you are in kind of a perpetual busy season. So I want to thank you for your time today and for educating our audience. And thank you all for your questions. A couple of final things that I want to share before we close out today. A video of this forum will be available next week, as usual, if you want to share it with people in your network who might be interested. I think people are here, there, and everywhere right now. May is just a busy month. So if you want to share it with them, feel free to. One final plug, we have a large event next week, and there is a QR code to direct you towards our tickets if you'd like to purchase tickets. Representative Rivera talked about AI today. It's a conversation that's coming up here, there, and everywhere. We are talking about it in the context of education and how our local leaders here in Lancaster are really prepared to engage with this challenge and have been. So if you're not signed up and you'd like to, please join us. And we'll look forward to seeing you next week. And I fear that, my final reminder, we will not be here next month. There is some construction going on here at the Ware Center. We will be at the public library, and our presenter is the Lancaster Public Library. They're talking about some new processes to potentially create a more sustainable long-term future for the library. So all of that information will be in the invitation, but you may be used to coming to the Ware Center. Just wanted to make sure that you're prepared to meet us at the library for First Friday in June. That is everything. Thank you so much for being here today. Thank you to our panelists, and hope you all have a great weekend.